Welcome to the Kaleidoscope, Healthcare in a Diverse America, from Molecule to Market, with your host, Sheila Thorne. Each episode highlights leaders and patients of color to discuss culturally, linguistically appropriate strategies and services. You can find this show on all the major platforms, including YouTube, LinkedIn, Apple Podcast, Spotify, and on our website, SheilaThorne.com. Now here's the host of the Kaleidoscope, Sheila Thorne.
Hello. Artificial intelligence emerged as a discipline and a science back in 1956 at the Dartmouth Summer Research Project in Dartmouth College in New Hampshire. After decades of advances and starts and stops and setbacks, AI is now creating much noise in the world, and especially in the health ecosystem. These 50 scientists and also mathematicians and data scientists came together and they started asking a question: can machines be made to simulate human intelligence? Can machines think? Can machines learn? Can machines solve problems like humans do? Well, it took them the summer to figure out some of the answers to those questions. But here we are now in 2026, almost 7 decades after that meeting, and artificial intelligence, or AI, is transforming the world in how we live, how we do business. In the healthcare system, it is rapidly, at an unprecedented pace, changing healthcare research, healthcare delivery, treatment, diagnoses, and all of what happens in the healthcare ecosystem. The adoption and integration is moving rapidly at warp speed. And it's not even giving us enough time to figure out what it is, how it works, and what are the long-term consequences. It's moving faster than we can keep up with it. But you've heard all the sayings. Artificial intelligence is here to stay. You can't put the toothpaste back in the tube. You can't put the genie back in the bottle. This train has left the station. I began educating myself on artificial intelligence about a year ago. And the guest we have today that we'll be having a conversation with was one of the first speakers I heard talk about artificial intelligence. And that was last year in Chicago at the meeting of the National Medical Association. And it was a symposium sponsored by the W. Montague Cobb Research Institute, connected with the National Medical Association. It was fascinating. After that, I attended a number of webinars and seminars, some online, some in person, to really learn about artificial intelligence. My year culminated in attending an international AI summit in Cape Town, South Africa, because I wanted to learn what artificial intelligence was doing around the world and globally. Researchers presented from the UK, from Germany, from Australia, from France, from Italy, from all over Africa. It was intense, it was inspiring, and it was scary. So I began to think, how will artificial intelligence affect the communities of color that I focus on in my work? Can it contribute to eliminating healthcare, racial and ethnic disparities that have been pervasive and persistent? And will it put us on the track to finally achieve health equity, quality healthcare for all? Well, to have that conversation, I am very honored and privileged to introduce my guest. His name is Dr. Hassan A. Tetteh. He's a thoracic surgeon, retired U.S. Navy captain, and associate professor of surgery at the Uniformed Services University of the Health Sciences and adjunct faculty at Howard University College of Medicine. Dr. Tetteh has had over 25 years of dedicated military service and global deployments. His experience as a thoracic and combat trauma surgeon is unparalleled. He has pioneered AI applications in healthcare, particularly in military medicine. His vision for AI certainly will enhance medical care. But to bring it home, he's a native of Brooklyn. He received his BS from the State University of New York at Plattsburgh, his MD from the University SUNY Downstate Medical Center, his MPA from Harvard's Kennedy School of Government, an MBA from Johns Hopkins University Carey Business School, and an MS in National Security Strategy with a concentration in artificial intelligence from the National War College. So there's no question in my mind that we are talking to the right person. So it is my great honor and privilege to introduce to all of you Dr. Hassan A. Tetteh.
Hello, Sheila. How are you?
I'm well, Dr. Tetteh. Thank you so much for joining us. I am excited and such a privilege to have you as a part of our conversation today at the Kaleidoscope.
And well, I must interject. I would be remiss if I did not do this. Anytime someone gives me an introduction, it's very humbling to hear all those great accolades you just espoused. However, you missed out, and I should always lead by saying only 3 things you have to say about me to introduce me appropriately, and then we can set the table and then have the conversation. You should have led by saying he's a father, a husband, and a surgeon.
Amen.
And that would have sufficed for the intro.
That would have covered it. Well, I'll remember that the next time, okay? But I always like giving you the just due for all of your education and credentials, but I got it.
And I often say, just so your audience knows, every time I hear one of those accolades, like, oh, he went to medical school. Well, what you don't know is that I got rejected from 50 medical schools before I got accepted to that one. So every time you hear, every time I hear one of those great things, in my mind, my subconscious takes me back to those dark times of all the rejections that preceded that one, seemingly awesome achievement. But
here you are now. Here
I am.
Yes. Well, I've got to tell you how I feel we are kindred spirits. I was born in the boogie down South Bronx.
All right.
Raised in the North Bronx, and my dad was a Navy veteran. So,
well, thank you for your service.
And you as well. Well. He was an awesome man, a wonderful father and husband, and he would have agreed with your listing what your real accolades are.
Right. Absolutely. Yes.
Well, we're here today, and the topic is a quite serious one, and it's yet a very exciting one as well. Yes. And behind you is the reason why I thought you would be the ideal person to bring on to have this conversation. It's your book, Smarter Healthcare with AI, and the subtitle, which you can't see very clearly, Harnessing Military Medicine to Revolutionize Healthcare for Everyone, Everywhere. Awesome.
Yeah.
An interesting read, a very provocative conversation in what you wrote and how you wrote it. And I thought our listeners and our viewers needed to really hear it from you, as they say, from the horse's mouth. Sure. And clearly, this is a watershed moment in healthcare, Dr. Tetteh. Things are rapidly changing, certainly a lot for the good, but there are some concerns.
Sure.
And so I wanted to start out by talking about data, because when you hear artificial intelligence, that's what comes to mind first. Data. Clearly, what is your thinking about all the public health data, the data that it has been given, enough for us to really do the job that it's purported to do?
Yeah, well, I think it's an excellent question. And I'm going to answer it by first setting the table for AI as we're going to be discussing it, and certainly in the context in which I'm approaching the answers to your questions, which are all going to be very good, I'm sure. And I think it's important to do because I've noticed when I speak to different audiences and in my interaction with my colleagues, whether they're on the tech side, they're on the clinical side, they're just, sort of professionals in different disciplines that aren't necessarily versed in AI. Mm-hmm. We're all thinking and talking about and potentially defining AI differently. So I like to, sort of set the table and provide a definition for how I am speaking in terms of the context of AI for this conversation, and pretty much how I approach most of the work that I'm doing. And it is it's sort of a very comprehensive and hopefully a definition that sort of encompasses what most people in this audience and your forum and community are thinking. So I think of it like this. As you mentioned in your intro, AI has been around for a very long time, decades, right? Down since 1956 is when the term sort of got coined. And then we've been through various seasons of AI, many different seasons. We might be in the white hot summer of AI right now, but we've been in a winter. We've been in the fall. We've been in the dark recess of the depth of the winters where no one was talking about it and not many were being made. So for the purposes of this conversation, the way I like to define AI, it is human behavior being mimicked by machines, machines mimicking human behavior. Mimicking human behavior being done by machines, machines mimicking human behavior. And for that reason, I think it's important to sort of start there, because now we're all kind of thinking and talking kind of the same language if you think about it. And there was a time when washing machines were considered AI because it was mimicking human behavior. And when your question, which is a very good one about the data, your question, I'm sure, is leading to what many people now appreciate with AI in this white hot summer of AI that we're in right now, where for the first time in perhaps all of the many decades that AI has been upon us as a discipline, as something that has been written about, researched about, this is perhaps since the advent of the large language model and ChatGPT in particular, that people that were not computer scientists, that were not necessarily tech aficionados, are able to use and interact with AI in a way that was never able to do before, right? With the large language models, you ask a question and almost magically there's this answer that gets produced. Yes. And the synthesis of that answer is coming from a model that has been trained on the vast expanse of human knowledge.
Yes. Yes.
And giving you a probabilistic, statistical answer for the question that you're asking based on what word will most likely come next in that sort of word string, right? So there's a lot of math behind that, but that's only one aspect of AI, believe it or not. Okay. It happens to be the one that's most front and center right now because, again, it's the one thing that now people can interact with. You know, it's never been lost on me how I'll talk to my colleagues and they'll tell me, "Oh, I don't use AI," and then they'll proceed to open up their phone with their facial recognition, and I'll just smile, and internally just say, "Okay, well, you do realize there was computer vision there. There was a whole process behind your screen just unlocking," but they are not perceiving that as AI. Again,
right?
Machines mimicking human behavior being mimicked by machines. So if I ask you a question as a human being giving me a response, we've been doing that since we existed as humans, right? Telling stories.
Time. That's right. Yes.
But now there's this computer, this thing that's giving us almost a magical response. It's mimicking our behavior. Just like the recognition of a face for the phone to open up.
Yes.
It's mimicking what happened before, where I have to put in a code or I have to do some things to get this screen to come up. So I just think it's really important to set the table. But now I'll come back to answering your question because it's a very good one. Okay. When you think about these models that we're using to get these kinds of answers, to get these kinds of algorithms that give us insight into a myriad of things, that data is the source of the building of the models and then what ultimately may be the answers that are produced from them. And when you think about sort of basic data science 101, there's sort of these 5 V's, call them 5 V's, that people look to for data, to sort of ensure that the data that is going to be building the model and then ultimately the product of that model that gets produced. And the things are volume of data. That's very important. Like you want to have a lot of data. You don't want to just have a little bit of data because a lot of data would be good. You want to have value in that data, meaning it's good data. It's not like, garbage in, garbage out. You've probably heard that from many people.
Oh, very often. Yes.
Right. Velocity, you want it to be timely. Like you don't want to have historic data. That's why even now the interaction with ChatGPT is so robust because there was a time when the first models came out, they were sort of accessing historic data, not real-time news data, right? Yes. They were sort of changed. It wasn't in the internet where news is happening today and you can actually ask a question now about something that just happened, like literally hours ago.
Almost real time.
Real time. So velocity, value, volume, those are the first 3 V's. And then you want to have variety. Because you want it to be diverse, which I think is something that's really important here, right? You want it to be diverse. And then the other thing that's important is, which is really, really important for us, is and I'm sure this is where you're going to go to with this conversation and for your audience, you want to have veracity.
Yes.
How is it true? Is it factual?
Yes.
Because if you have a model based on incorrect information, untruths, or things that are not accurate, then whatever that product is going to be will be something that will be based upon something that's not true, something that's inaccurate. And that can lead to a lot of problems, particularly in healthcare, right? I mean, it may not be such a big deal if you're, maybe it gives you the wrong direction. It didn't give you there wasn't really a street there, right? And the GPS sent you down this street that doesn't necessarily exist. Well, that's a problem, but it's not a consequential problem as long as someone drives off a cliff or something. But in healthcare, that could be a tragedy, right? Is it the wrong dose, the wrong molecule? Is it the right diagnosis? Those types of things could be a real problem.
That's exactly where I was going, Dr. Tetteh, because clearly for diverse populations, the quality of the data then becomes a critical element to consider. What are you basing that data on?
Right.
And one of the first books that I got to read about AI was called AI for Dummies. and it had a sentence in it about the data. And it said, as long as we keep asking one audience for information and not the population as a whole, the data is biased. So
that's correct.
Clinical research is based on one particular population, and physicians and other healthcare professionals extrapolate that to apply to other groups, which may or may not work. So is that of concern to people who are treating diverse groups?
100% it is. I mean, it's the same type of thing that we have known, right? If you do any kind of research in health disparities, anything in the health research services domain, that there are inherent biases that are just a product, a consequence of a great number of things that we can't even enumerate here in any great detail.
Yes.
And what AI can potentially do, especially if you think about some of the data that the models are being trained upon, it can amplify those biases, amplify those disparities, amplify those inconsistencies with how people get care, how they receive care, and ultimately their outcomes, right? So you're absolutely right. That is a concern. Now, I don't want it to be entirely negative, because I think that at the same time, one of the things that has happened, and you're seeing it now, is that this tool, the large language models in particular, and some of these models that have been developed that are being trained on the literature, the medical research, they're being accessed by people who may not have had access to any care before.
Oh, right. So that's a plus. Definitely.
That's a plus, potentially a plus. Now, they may be getting information without the appropriate context, and maybe not with the input of some healthcare professionals that may be using their clinical data to better inform a decision and a care pathway for them. But nonetheless, what you're, I think, going to start to see is more people relying on some of these models and some of these platforms to get information where otherwise they would not even have had access to it. They may be going to Google, and you've heard the term Dr. Google and so forth. Well, in my opinion, it'd be much better for them to access information that's being based on good, sound scientific data and research data that has more applicability and application to their particular condition. And because and that's the goal, right? And the other thing that I think is becoming a little bit more accessible is this is a bi-directional sort of phenomenon, because you can ask questions, but you can also provide information, your own personal information. I have a watch here. I think when we think about all of the data and things that are now being captured by sensors that you can now get insight from on your own, right? And before that you couldn't tell, like, well, what was my, how did I sleep, or what's my blood pressure, and well, my heart rate's really high. That's interesting. Is it because I just walked up a flight of stairs? Am I stressed out? Those things can help give insight into things that are happening, daily in your lives in a way that could potentially help you start to change some of your behaviors.
Exactly.
Now, if you couple this, right, taking some of this data, inputting it into, a platform where it's going to look at your data, marry it with the questions that you ask and the available literature, now you have, sort of a unification of insight of information that can give you an insight you never had before. So I don't think it's entirely bad.
No.
I think it can actually help enhance the accessibility for some people who otherwise don't have, any means of really accessing care in a meaningful way beyond just going to the emergency room.
I think you're extremely right. And one of the things that I have worked on in my focus has been increasing the representation in clinical research, so the data do become more robust and more applicable to the end user of that product or that device. And I think that's one of my goals. That's why I created this Equity AI, more inclusive healthcare, more people who are going to be using the product, the device, or the intervention surgically, so that doctors can be comfortable that it's safe and effective in everybody, whatever that may be. So I applaud the fact that the accessibility is increased. And I think that's something we need to talk about, educating patients, consumers, caregivers, family, that here's how you figure out in coordination with your doctor, what's the best treatment or the road to take. So
I think you nailed it there, which is very important. In coordination with your doctor and your healthcare team. Ideally, you have one. I am very, I'm very sensitive to the fact that not everyone has access to it. That's why I said, in some ways, this could be the beginning of providing some insight to people where they would have absolutely no direction, no insight, no information at all. And it can ideally enhance the encounter, the engagement, and the partnerships, right, that we all have as patients with our healthcare teams.
Critical.
I'm never I'm never at a loss to highlight how important this time is, right? Unlike any other time before. If you think about the doctor-patient healthcare system relationship, it's been the patient goes with their anxiety, with their fear, with their uncertainty, with their unanswered questions to the all-knowing doctor, the all-knowing healthcare team. Well, that's not the case anymore, right? Because as I mentioned, I have this device here that's capturing, a lot of sensitive and sometimes very helpful information about me and my environment and how I'm interacting with food, with drugs, with medication, etc. And I have now an empowered sort of agency to now take that information, right? And by the way, I asked some good questions to ChatGPT that, they may or may not be right, but at least it gives me a little bit more perspective on what may be going on with me. And now I can come to the encounter, I can come to the appointment, I can come to this sort of engagement with my healthcare team more informed. And think about that. That's a powerful thing. So now it's not just unidirectional. I'm telling you what to do. This is what's going on with you based on a 15-minute, interview and some vital signs before that. Now I've been monitoring my blood pressure and my heart rate, and I've been watching what I've been eating and what I've been drinking, and I can see that I had a very stressful time here, and I had some relaxation here, and this is how I slept. And I have all of this data over months, doctor. And I can see what things have happened and how I feel. And I look some of this stuff up, and I'm coming to you, and I'd like to get some of your insight as I help to help me understand what's going on, so we can kind of come together as a team and figure out what the best way forward is, whether it's in the diagnostic capacity or if it's in a modality to treat something that may be ailing me.
Exactly. Well, it definitely enhances that clinical encounter. It makes that a much more meaningful opportunity for a two-way conversation. So I appreciate your thoughts on that as well. But now let me go to your military background, because that I think was the most fascinating part of your book, and how you looked at AI as a tool and how it could help you in the 90 seconds you had to make a decision on a battlefield while bombs were flying and the resources were optimal, but yet AI helped you in terms of making sure that our service people were treated and hopefully get into a position of being recovered or transported to other places. And you talked about it in 4 ways that I thought was interesting. One, using AI as a predictive tool. Talk to me about how that seemed to play out in your military experience, and is it referenceable in clinical care?
Sure. It absolutely is. And Before even answering that question, and I'll do so by sharing a concrete example of exactly how we were able to achieve what you just outlined. It's important for the audience to know, because it's not intuitive, and it certainly wasn't intuitive for me, even being in the military for many years. It was because I am a student of history that I really sort of delved deeper into the evolution and the genesis of a lot of the modern things in healthcare that are absolutely impacting and saving lives that we take for granted in terms of where they came from. One of my former surgeon generals, and one of the surgeon generals that I worked for in a capacity of being his policy advisor, was always fond of saying, whenever he had the opportunity to talk in this way about what is the impact of military medicine, and he said that unfortunately the only good thing, sometimes only good thing, there are not a lot of good things about war, but one of the good things about war is that it tends to advance military medicine, and by extension civilian medicine. And you might be like, well, what do you mean by that? Let's go back all the way to for the purposes of our discussion here, United States, Continental Army led by Washington. When Washington was much younger, before he assumed his role as the general and then ultimately the president, he suffered from smallpox. So he knew about how devastating this disease was. And they didn't have, robust vaccines back then, but what they did have was the ability to inoculate someone with a small amount of smallpox by bursting the pustule and exposing someone to it. This is a small amount. And that would, they would notice that would give that person some immunity to it. So if they got a little bit of exposure, they were able to build an immune response. And so when he was in charge of the Continental Army, he ordered the varicellation of the soldiers. So these people were exposed to smallpox. It gave them an immunity, and that gave us a decisive advantage on the battlefield. Wow. If you think about most wars across the history of humankind, it's not the bullets that kill people, or the swords. It usually was disease and infection.
Yes.
And so you think about it, the British Army, they suffered major losses from smallpox. We were sort of immune from that, so that helped us. So that was really the beginning of like this mass vaccination protocol that was really one of the spearheads for having public health be an integral part of warfighting. Making sure that if we were going into a place where there was going to be yellow fever, we would get vaccinated for it. And, in the military, you're just used to that. You just line up and they give you all kinds of vaccines for all kinds of things. And you just keep going. I know there's a vaccine controversy now, unfortunately, but really that's where it came from. The Civil War.
Interesting.
People would get injured and would have, a leg or extremity injury and would have to get an amputation. You lose a lot of blood. The first recorded blood transfusion was in the Civil War, and that was the beginning of the Army blood banking blood. Now we go to the hospital if you're a victim of trauma, or you need blood because of anemia from some other condition or cancer. There's blood available. But that whole process was began in the depths of the Civil War, and thinking about that. Something as simple as washing your hands. It was a British surgeon, Paul Lister, that brought in this concept of antisepsis. Before that, surgeons, I like to show this as this is the surgeon's sleeve, because you can unbutton it and you roll it up. It's because back in the day, the surgeons were more concerned about getting soil on their clothing. They would just roll up their sleeves, not wash their hands, by the way, and they would dissect the corpse and the body that they were using to train the medical students, and then go right into taking care of a real life patient, not washing their hands and transferring all these germs. And you're shaking your head and you're like, why would you do that? That's terrible. Exactly. That was the practice of the day, because people didn't know any better. And it was because of a British surgeon, again, that military background that came into play. And it took 30 years for them to adopt this antiseptic sort of posture. But to answer your question now, how did that translate into the battlefield? Well, exactly. It turns out that, we have in the military for years always have been thinking about, how do we take care of our wounded warriors? How do we ensure and preserve their health in a way that doesn't jeopardize the team that's taking care of them, and can do so in a way that, we could scale. If it's one person injured, two people injured, or a whole battalion injured, can we take care of all those people without taxing the resources? So you think about triaging and things like that. Well,
I was just thinking about that.
Yeah, what about having an autonomous system where you could tell, like, hey, this person may need a little bit of care. This person may need a lot of care. They may need to be prioritized for evacuation. Well, we've been working on that with our colleagues at DARPA, with our colleagues at Tetteh. These are all mnemonics for different organizations in the military for years, because we know that, any successive battle and campaign that we're going to be in, there's going to be casualties. There's going to be potential for mass casualties. And we want to maximize and preserve the opportunity for people to come back home to their loved ones. So we are pioneering a lot of those things. And one of the examples that I have in the book highlights how we're able to use blood pressure and heart rate as a measure in the field to predict who is going to need a blood transfusion. And think about that for that triage example now.
Yes.
Now, why is that important? Because on surface, sometimes you can see someone, and I've had this experience in trauma, throughout my career as a surgeon. You look at someone and like, oh, but they don't look too bad, but you may be missing or not appreciating the full extent of their injuries, particularly if it's an internal injury.
Yes.
And then you see someone with maybe their arm is severed and they have a tourniquet, and you're like, oh my gosh, that person looks like they're in really bad shape. Well, actually, no, it was actually the person that looked okay.
Huh. Wow.
They look okay now, but in a few minutes they're not. And so think about having a tool, and in this case, I described it in the book, where you can just take their heart rate and just take their blood pressure, and because of algorithms and based on a bunch of training and algorithms and models that were developed, you can say, hey, wait a minute, no. That first patient you saw, they're in much more extremis. You need to direct your attention to that person. The person with the arm that's hanging off, but they have a tourniquet there, the bleeding is controlled, they don't have any other injury, they'll be okay. Tend to this person first. So you can see how that becomes very valuable. Now, that's the microscopic view. Take that to the macroscopic view. Another example in the book that my colleagues and I were very honored to be a part of was a project called Project Salus.
Yes.
Now, take us back to, the audience, I'm sure will remember, we all went through this global pandemic. It turns out that in the history of mankind, pandemics have happened, once every 80 to 100 years. So it's something that just happens. And we just happened to live through one recently. We're still living through it. But in the depths of that pandemic, if you recall, in the early spring of 2020, when there was a lot of uncertainty and everyone across the country, dare not I say the whole world, was experiencing COVID in a different way. Experiencing COVID in a different way. Certainly if you were in New York or in LA or Seattle, these very big epicenters, you were experiencing in a very real way initially. I know I had family members that I lost in Brooklyn. But in the middle of the country, it was like, well, what's going on? What are those people on the coast worried about? Like, why are people wearing masks? What's happening? They didn't understand it. So our testing wasn't very good. And so when we were at the Jake, we were also faced with everything else that the public was facing, because we had families ourselves, right? We were experiencing this as well. And we knew we had capability, right? We had the smartest people from, data science, the smartest people that were AI engineers, and we had all of these computing resources available to us. And we started to brainstorm about how could we, in a place and in a time when there wasn't really a lot of testing and a lot of information about this very terrible condition, how could we do something? How could we build a tool that would help? And what we came up with, believe it or not, Sheila, was a model. We built a model based on Medicare claims data as well as supply chain data. So we took supply chain data from our commercial partners like Amazon and UPS and all these different places that were shipping supplies to different places. We took Medicare claims data, because even though there wasn't at the time a CPT code or some robust way of measuring who was sick, people were coming into the hospital all across the country in different ways. They're going to clinics, they're going to ERs, and they were coming in, and at the time they were getting diagnosed with flu-like symptoms. So we assumed, we made an assumption, which you almost always have to do when you're making sort of a theory. And our assumption, I think, was pretty good. I mean, it was based on flu-like symptoms, which at that time, given the volume of people coming in with flu-like symptoms, they probably had COVID. And we used that claims data, and it was a little bit dated. We got better at getting more accurate and more high velocity data that was coming in more real time. And we built a model, and we were able to predict down to the zip code level across the entire country.
Wow.
Where COVID cases were going to erupt.
Yes.
And
yes.
your audience might be like, well, what's the value of that? Well, think about it. You have a map of the entire country down to the zip code level. And in our model, the shaded areas that were dark, the darkest areas were where there was going to be the highest density of cases, most likely.
Okay.
And we validated.
Yeah,
we were for exactly preparation. We validated that by taking the hospitalization data, which we would get also, and overlaid over those places. And you would see there was correlation. So a dark circle was heavy, dense hospitalization, almost at capacity if it was red. Overlaying that on the dense area on the map, and you're like, oh, you could see, there's validation. And our models got better as time went on. But that tool was being used to sort of help deploy where our resources were most needed. Right? Rather than take a shotgun approach and just try and blast people all over the place, meaning people like the National Guard, nurses and doctors that wanted to volunteer, resources. Remember how precious resources were: gloves,
very precious,
masks, personal protective equipment. Like, let's not send it to the middle of, the desert where no one is at and needs it right now, but let's send it to one of these zip codes where we can see in a couple of weeks it's going to really be necessary there, because there are going to be a lot of, injury. There's a lot of sick people.
That's fascinating. And, I heard the same kind of argument in South Africa for a gentleman that talked about cholera outbreaks.
Correct. Yeah.
If you could put in all of the factors that would lead to an outbreak in advance, you could get
to you could get to a place where you can intercept the trajectory of the outbreak and start to put in place the public health measures that could arrest or curtail it. Correct.
I don't think people really connect AI with something of that magnitude, but that's important. And you also talk in the book about suicide prevention. Correct. I found that to be fascinating, because obviously for those who are in the military, this can be a problem and has been historically. And really in ethnic groups, there's the highest rates of suicide among young people in the Native community and the Black community, because of living in very stressful environments and, difficult situations. That I found extremely fascinating. So you get to somebody before they get to that point.
Right. And there's still a lot of work to be done. And I certainly don't want to discount the work that so many people are doing right now and continue to do in this space. It was a very challenging problem. It is a challenging problem. And for us, we made a deliberate decision to try and address the problem. And it took leadership. It took the support of our entire cadre of leaders to sort of give us the license to go ahead and do this, because it was a very controversial, very sensitive, very delicate topic.
Yes.
And so our approach was, we knew we were not all clinicians. Certainly I'm a physician, I'm a surgeon, but not all of the people that we're working on with the team were. And we knew we weren't behavioral health professionals, but what we could do is give insight into those people that were taking care of people who were at risk for self-harm and destructive behaviors and things like that, and unfortunately suicide. And Sheila, how we did that and how we approached it was with convening a body of experts and a team of experts that were behavioral health scientists and practitioners. And we had access to a resource and a data set that was quite unique. In the military, unfortunately, when someone passes away through suicide, it is considered, for all intents and purposes, a crime, if you will.
Yes.
And as such, it gets investigated like any other crime would. So it's a composite profile of that person's professional, health, economic, social data, all of that put together, interviews with family, interviews with friends, interviews with spouses, commanding officers, peers. And we put together a report that can oftentimes, depending on the person, could be hundreds of pages.
Yes.
Well, and now these are for people who have committed the act. They weren't attempted. They committed the act. They went through it. And what we took that data, and we used natural language processing at the time because it was the tool we had available to us. So we go through this data, a big report that had pictures, that had handwritten notes in it, sometimes that had digitized data, that had health records in it. And we synthesized what we called an ontology, right? Sort of the essence of what this person was and who they were. And started to see patterns, that we could say these were the triggers. These sort of seemingly disparate things were all in common with these people.
Yes,
what were the
yes.
stress factors? And the idea was to build an awareness for the things that would be triggers potentially, or at least the things that should be identified or could be identified in individuals within a unit for someone that may need intervention and may need help and assistance. Give them that information. So it was the beginning of, I think, more important work to come. And right now there's a myriad of tools that are being used, and I happen to have been fortunate to be exposed to some of these novel technologies and advances that are working with healthcare professionals to provide care in between sessions, in between patients that are taking their medication to ensure compliance and things like that. And I think we're just starting to see just the beginning of how AI will be used to help ideally curtail and decrease the amount of behavioral health issues that lead to, unfortunately, suicide and self-harm.
Well, it certainly can lead into the law enforcement concept as well, in terms of helping people that may be at risk and behavior-wise. Last one about the tools, and I think this is one that's critical: treatment. How can AI be helpful to enhance treatment recommendations by your healthcare professional, and what impact that does have on me as a patient?
Yeah, again, I'll go macro and then kind of come. Okay. So I'll go Google Earth view and then come down to the molecule, right? So at the Google Earth view, I think what you're starting to appreciate, and you're seeing this every day in the headlines. There's a lot of sort of population health that is being influenced by some AI discoveries, looking at pattern recognition, whether it's how the environment in a particular area is impacting the health of others, those types of things at a very macro level. Drug discovery at a macro level, again, you're starting to see we can create these disparate pattern recognition type of tools to help us with some of the drug discovery with AlphaFold and all these other different very cool things that are happening. And then at a molecular level, if you think about cancers, right? Cancers are, and we've learned this more and more every year, that there was a time when cancers were sort of treated in a very almost kind of blanket standardized way, where cancers are bad cells, or cells that weren't normal that have gone rogue. Let's just kill the cells. Well, you're also killing all the good cells as well.
That's right.
But now you can target that therapy to their certain characteristics of the cancer cell. So you can design drugs, treatment modalities. You can autoimmune responses, so to speak, where you're not using a drug necessarily, you're modulating the immune system to go after a cell that is abnormal, that the body doesn't necessarily recognize, but you can modify the immune response by targeting that cell and then having the immune system go after the cancer cell, which is what usually happens. We always have rogue cells in our body that are damaged, that are not working right, and the body just takes care of it and eliminates it. It's when those cells kind of overgrow or outpace that natural mechanism of control that you get out of balance and a cancer evolves. AI is being used to sort of help develop some of those targeting, some of that molecular and immune regulation that's helping to enhance the efficacy of some of these drugs. And that's just the beginning. We're just seeing the beginning.
Amazing.
And we also have, even take it down even a step, further than that, down to the DNA level, like being able to find, as the human genome has been mapped. Where are those targeted defects in the newborn, the yet to be born, where you can go in and excise that piece of DNA that has an error in it, that's going to lead to a phenotype, meaning take that genetic type and then manifest it into like the sort of the protein and all that stuff that's abnormal, that's going to be harmful, that leads to morbidity and mortality. Can you fix it at the genetic level before it manifests into it becoming a problem later? Yes, we can do that, and we are doing it. CRISPR technology.
Personalized medicine, getting right to the heart.
Personalized medicine, exactly right. That was all of that background to say we are using AI, and we will continue to use AI to be I think, really at a place where we can achieve personalized medicine. You know, what I
Exactly.
talk about in the book of that framework of purpose, personalization, and partnership. That personalization part, I think, is going to be enhanced tremendously through AI.
Huge. And patients need to know this, Dr. Tetteh. I mean, this is information that people who may be given a diagnosis that in their minds may be a death sentence and nothing can be done. And yet these are the tools that can help really focus on where the problem is.
Oh, 100%, 100%. And I'll give you another example that I can't help but, put a plug in here for. And that is, we have many models, right? Like I said, we talked about ChatGPT, but there are other models out there. I'll just highlight one in particular because it illustrates the point that you're getting at, where the patient and the provider can now be empowered to do something that they were never able to do before, not at the scale and not at the precision that they could do before. So since I've graduated medical school, right, there has been a plethora of new information that I could never, even if I had 12, 20, 50 lifetimes, synthesize all of it. That just is not possible. Even in the time that we started this discussion just a few minutes ago, there's been new research that has come out that may have implications on me as a personal individual, or on the patients that I take care of that I may see tomorrow or next week or maybe a year from now, and I'm just not going to be aware of it. So one of these tools that's being developed, large language model, Open Evidence is the company's name. They've taken all of the literature, so it's not just the internet and people blogging about I use this elixir and it helped. No, this is the randomized control trials, the creme de la creme of research coming from New England Journal of Medicine, Journal of American Medical Association, you name it, like the very top journals all across the country, the best scientists working on some of these things. And that is the data source. So you want to talk about the 5 V's there, right? That's a lot of volume, a lot of veracity. Maybe they could do a little bit with the variety because some of those trials don't necessarily include all of the people that, may be impacted. But nonetheless, it's a lot more truthful than maybe just getting internet data from everywhere else. And doctors can go to this as a source and ask questions. Hey, I have a patient that has this particular mutation on a gene, and they have these constellation of symptoms, and they have these, manifestations, and they have this family history. What would be a good treatment? And hey, now it's going to go through all of that, basically the vast expanse of all the literature, good literature that we have compiled over, the collection of medical science, and now give you some insight that may be very helpful and may say, hey, there is a clinical trial going on right now at, such and such center that this patient will be ideal for. Think about that. That is incredible, right? So your death sentence, which may have been a death sentence maybe a decade ago or 2 decades ago, now is can help you get informed about something that may be very
It gives hope. It gives hope where there may not have been any. And again, I think it emphasizes from what we said at the beginning, educating. The AI literacy, I think, needs to be high on the agenda as it evolves as rapidly as it is. There are some things that you're suggesting are there. We need to know those things, and people who have a predisposition for a certain condition or family history, as in some cancers. I think all of that is important to show people you can take charge and control because you've got the information and the tools to it. Well, let's wrap the conversation up in an area that I know is very unique to you and what your life experience has been, and that's elimination of healthcare disparities. Now, you are not only a proficient clinician with enormous and vast experience, but you're a man of color. And these disparities do affect all of us, but especially clinicians who are treating people of color, who may be insured, who may have education, and are still dying prematurely from manageable, treatable disease. What can AI do to help us finally get the road to health equity? But we've got to first eliminate disparities. Can AI help us there?
My short answer to that question is yes. I am optimistic that it can. My optimism comes from a number of places. One, it would be hard to be where I'm at if I wasn't an optimist. I'm a son of West African immigrant parents, and I'm a physician who served 25 years in the Navy and retired as a captain. If I wasn't a positive thinker, that would never have happened. So,
It wouldn't work.
let's start right there. So I'm an optimist by design. It's in my DNA and my core. And I do believe that AI gives us the great potential to do a great myriad of things, including eliminating or minimizing disparities and achieving health equity. How will we get there?
Yes.
One word: leadership.
Leadership. You got it. Yeah.
It will take leadership. So my short answer is yes, and it will take leadership. And I'm not suggesting that it's easy. No. I think AI gives us the opportunity to accelerate our ability to close the disparity gap and improve equity. Now, there may be a lot of people that don't agree with that, and that's fine. But I've seen AI's potential at the front line. I've seen it at the enterprise level, and I just see it every day in the work that I see is being done among a number of people. And just as we talked about how AI gives the patient agency, and can empower them to be better advocates for themselves and their health, and being even care providers for people that may not have the sophistication or may not have the access to some of these tools, you can now enhance people's ability to access care. So I think on an individual level, there's a lot more opportunity now to close a disparity gap and to achieve a health equity that you couldn't do before. So if you put the onus on the individual, and I'm not, trying to shift the responsibility, but I'm saying it's easier now for individuals to get answers to things, just basic things that they probably could not have done before. And I'll tell you something, and I'm seeing it happen. I was on a panel, and one of the providers told us a story about how a woman who was one of her cure patients told the physician, they asked her about why she couldn't take her medication or what have you. And she said, I can't afford to take my medication. I didn't have the money to pay for the copay for the prescription. But I went on ChatGPT and I asked, what could I do?
Wow.
And she found an answer, and it gave her a little bit of insight into how she could go about procuring the medication that she needed in a way that didn't require that copay. Now, that's an example that might be like, well, that's kind of trivial, but how could you have done that before? Because it gave her information and connected her with a resource that allowed her to be innovative, right? And to be resourceful and to be a problem solver. Now, if you think about taking that at scale, that in and of itself could do a lot. Yes. But I don't want to just put all the onus and burden on the patients, because they're the victims of all of this. The fact is, leadership can help us with that. So as these companies are building these models, as government is regulating these models, there are opportunities, I believe, to ensure that data has variety, that data includes people, because it's not only going to help a certain group, it'll help population. So you remember, I'm sure, during the COVID pandemic, how there was a lot of discussion about like, well, we're just going to take care of this group over here and just take care of this group over here. We're not going to care about those people. Well, it turns out that diseases and viruses in particular don't care about borders.
Equal
so it is everyone's interest. it's in everyone's interest to ensure the health of the population.
Yes.
America's healthcare is our national security imperative. I say that all the time. I write about it in my book. America's healthcare is our national security imperative, because without health, nothing else matters. And particularly if you're talking about a disease that is an infectious one that's communicable, and you're going to talk about, well, I'm only going to take care of this group of people, and I'm not so worried about those, you will soon find out that everyone will be in the same boat, and it won't be a good one.
That's exactly right.
So there's that. But I think going back to that leadership part, I'm not naive to the fact that, people like me and people that have been working in this AI space, and certainly the technology and those selling AI, we're very enthusiastic about it. Oh, yeah, this is great.
Yeah.
There was a report that just came out by Stanford. It's called the Stanford Institute for Human-Centered AI. It's called the 2026 Index. I'd encourage you to get it. It's online. Okay. And perhaps we could put a link in it and some of the verbiage here. But it talks about a lot about AI. It's over 400 pages. It's an incredibly rich study. One of the things that it ends with, or the takeaway, is that they're about 70% of the technologists and all these people working in AI that said this is going to be the greatest thing, AI, that is. But only 23% of the public feels so. So, there's not a lot of, congruence there. Why is that? I think it's because the people are anxious. They're not sure. They're hearing about AI is taking my job, it's going to replace me. I can't trust it. What if it gives me an answer that's wrong? It's going to hurt me. Right. These are all absolutely valid things, which goes back to what I said before, right? Yes, disparities can be addressed. Yes, equity can be achieved.
Leadership.
It'll take leadership. It'll take leadership, like the leadership you're displaying here by having these conversations, by having equity, AI, inclusive, ethical healthcare conversations, and organizations that are promoting this discussion, this conversation.
We need to be at the table. We need to be at the table. And, less than 2% of diverse groups are involved at the level you're talking about, less than 20% of women. So, you can't talk about us without us. So I think we've got to take the position to be at the table, to ask the hard questions, not that we have the solutions, but the voice. You've talked about it. You've got to be a part. The collaborative spirit of maintaining health and achieving quality health has to be a group effort. It's the collectivism. And I think you use another word in your book, consequentialism. We've got to figure out, if I do this, what are the consequences? Give me some options so that I can take charge of my health. And I think that's a spirit that your book even displays: compassion, empathy, humanity. It's not about us and them. It's about all of us. It's the together that we're going to achieve what we've already done thus far. I went to a program at Columbia University on Tuesday, responsible AI. What does that look like? Transparency, accountability, making sure that people make informed decisions, but being intentional about what you do. And clearly, my mom was a nurse. My sister was a nurse. I asked the hard questions, so clearly it helps me to help myself and others that are looking like me. So the work you're doing now, you're retired, you have this incredible, vast experience and expertise. How are you using that? Where are you going with that now so that you can continue this dialogue?
Yeah, it's an excellent question. At a high level, I'm continuing to teach. I teach, as you mentioned, and you enumerated a couple of institutions I'm still affiliated with, the Uniformed Services, Howard. I'm also faculty at the Center for Digital Health and Artificial Intelligence at Johns Hopkins Carey School of Business, one of my alma maters. I have a lot of them. I'm still leading in whether it's in thought leadership, like having conversations with you, writing about things, giving keynotes and speeches. I'm consulting. Again, I feel that's a way of teaching and informing. I'm still a healer at my core. That's why I said, just to say father, husband, and surgeon would have been good. That would have been. I'm still operating. I still contribute clinically. I still take call at hospitals. I'm leading an effort across the entire country with organ recovery. It's a specialty. My specialty is heart and lung transplant. There's a lot of disparity in transplant. There's a lot of inefficiency in transplant. I am bringing AI, my experience and expertise from the logistics arena, from my combat, surgical training and experience and expertise to heal. And most importantly, as I think sort of this next chapters or the next and evolving chapters of my life, it's to create, continuing to create more books, more writing, more poetry, more artwork, whatever it is. Creation to me is making connections. So even if I can bring and convene great minds together to have these important conversations, I think that's creating the energy that will engender the leadership that will take us forward in this next new kind of domain and frontier. And then quite frankly, I'm excited about it because I think about all of the things that are happening, right? A couple of years ago, I got the opportunity to interview Dr. Crystal Johnson. I'll give her a personal shout out. She was at the time the woman that was in charge of the medical portfolio for the Artemis mission to Mars. Now, when we were talking together, we had a conversation. We were talking about AI and how AI was going to have its influence on some of the things yet to even be discovered, Sheila. Like, think about it. This was 2 years ago. We're talking about the Artemis mission to Mars. And I'm sure people probably listened to what we were talking about at the time, and they said, Mars? When are we going to Mars? How are we going to? We just came from the moon.
That's
Artemis.
amazing.
That's the first step of many, right, to get us there. Mm-hmm. And we were talking about we have to invent things that have not even been invented yet. Mm-hmm. What if one of those astronauts had a condition and needed a CAT scan? Well, they couldn't put a CAT scanner in there, but we still need the information. So maybe we need to figure out how can we create or design or invent something that could give us the same information a huge CAT scanner could give, or an MRI, like Star Trek, a tricorder where you can and get a diagnosis. Because you know what, we may need that. It lies maybe on the line.
Absolutely.
So I think what's exciting is like having this imagination to think beyond now.
Yes.
And we have these tools, right? These technologies that are helping us to advance.
Yes.
Technology will always be around to help us do things better, but it will never really answer the question of how we do things better.
That's right. That's right. And you've retired from the military, but you certainly haven't retired from doing what you do.
I haven't retired from life. I've transitioned from the
life.
military.
There you go. That's exactly right. And that's what inspires me when I talk to clinicians and researchers like yourself. Because I really want to make sure that the bottom-up piece, the consumer, patient, education, literacy, works along with the top-down. As the brilliant people like yourself are working on those big issues, we're still day-to-day trying to make sure that we're safe, our families are safe, and the healthcare we get is quality, and it's accessible, and it's cultural and equitable. So I'm excited about this opportunity. I don't put down AI. I just want to make sure we use it properly and it's available equitably, and so that we all benefit from it. And I think that's part of why we all need that collaborative spirit. I'm going to end by reading the last few sentences of your book. And it says, AI will change and impact everything except the things that matter most. Indeed, the things that matter most and serve to connect us as humans, love, friendship, fellowship, and care, will endure even in the darkness and uncertainty of our AI future. And I think that says it, because the things that matter most is the humanity and the ability to make sure that we are our brothers and sisters' keeper. And we want to make sure that everybody has the same chance to live a quality and healthy life. And AI definitely gives us, I guess it gives us an excuse to revisit these things that really matter most. Sometimes we forget that in the chaos of life and the urgencies of the need. So I know that I'm going to make sure that whatever I learn, I transmit to people, and to make sure that they understand, when you know better, you do better. Okay. So clearly, once you know, then it's up to you to use it. Now, where can the people listening and seeing this get your book?
Oh, it's available in lots of different places. Of course, Amazon is a pretty easy place to go get it. It's available on audiobook. I'd highly recommend that one because I narrated it, so I'm pretty proud of that work.
Okay.
You'll hear my Brooklynese come out in that narration. So, but I consume a lot of books, and
I do as well.
Audiobook has been very helpful to do that. Sometimes it's hard to actually turn the pages, even though I do that as well. But audiobooks have been a really good pastime for me. And so I would encourage everyone to read it. And I hope it finds, gives people ideas. And I hope they find it entertaining and instructive and most of all, inspiring. I want to really inspire people. And I wrote the book intentionally, and I hope you appreciated it, to be evergreen, because I know AI is changing, right? What I define as a behavior being mimicked by machines could change tomorrow, right?
Exactly.
Again, it's just something evolving. So I have principles in there and the stories that I think are evergreen in terms of showing how whatever AI does become in the uncertainty of our darkness, that we maintain our humanity, but we're inspired to lead and to impact its direction and its trajectory.
Well, health is wealth. And so no matter what you do, that has to be a part of it. And my mom would always say, if you have your health, you have everything. And clearly when our health is jeopardized or when it's damaged, that's when we need the brilliance of what scientists and researchers like yourself have been doing all along. And we want to be able to make sure everybody has access to those things so that we can live a full life, that we have before us. So it's been an honor. I mean, I can talk to you for hours. And as I say, I've marked certain parts of your book. I've reread them, and I'm going to incorporate some of those ideas and put them out there and make sure that more people of color have these conversations, are at the table, so that our voice is heard, our unique life experience is heard, not as the afterthought or an addendum, but in the mainstream of what's being talked about. And I think that's the goal here. And I can hear your passion and spirit, and I thank you for all that you do. And I appreciate the efforts that you've made to stay in touch and to stay awake and alive and alert to this. And we can do this. My mom was a very spiritual woman, and she used to say, cast your bread upon the waters and it will come back to you. Absolutely. So we do all the right things. So father, husband, surgeon, I thank you. I appreciate you. And we hope you be safe and take good care. And we will spread the word about listening to this conversation we've had. And hopefully we'll be able to spur some others on to join the movement, the AI movement, and help people to see that we're living at a time when the glass is definitely half full.
That's correct. Well, thank you.
Thank you, Dr. Tetteh. Take good care. Bye-bye.
Okay, you too. Thank you, bro.
You've been tuning into the Kaleidoscope, Healthcare in a Diverse America, from Molecule to Market, with your host, Sheila Thorne. You can find more episodes on all the major platforms, including YouTube, LinkedIn, Apple Podcast, Spotify, and on our website, SheilaThorne.com. Thank you for your positive reviews, comments, questions, and for sharing this show with others.